hear me, if my signal gets weird. I'm on Wi-Fi at home, as I'm sure a lot of you guys are as well. I also said earlier, I've got dogs in hardwood floors, so they're sleeping at my feet. I'm hoping they stay that way. So if there's any difficulties, just give me a shout out. I have the chat box open. And I want to thank everyone for joining us. I want to thank the Westmoreland Drug and Alcohol Commission for inviting me to come out and, well, not come out, I guess, stay home and speak to you guys. It's definitely kind of an unprecedented thing. I've never really done anything like this before. So bear with me, but I definitely appreciate you guys participating. For those of you guys who don't know me, my name is Lisa Huffman. I am the team lead for the community engagement team at Westmoreland Drug and Alcohol Case Management. And Prevention at the Drug and Alcohol Commission asked me to come out and give you guys an overview of what the community engagement team is, how we function, and what we do for, I think, especially families in Westmoreland County and the individuals who kind of tend to fall through the cracks. So I have a little bit of data for you guys from Westmoreland County relating to our overdose rates, the age groups that those occur in, how that impacts the individual and the family, and how CET responds to that. So I'll say CET, it stands for Community Engagement Team. We are, in short form, the way that I compress it to kind of talk about it is we are like Westmoreland County's mobile drug and alcohol crisis team. But I will get into that here in just a little bit. And if my PowerPoint will work, and let me click through the slides. So this PowerPoint is adapted from a presentation I gave to the School of Social Work at the University of Pittsburgh a few weeks ago, actually before all of this started happening, because they wanted some commentary from field professionals on what we do for families, because in a lot of like open roundtable discussions, our communities, our local communities are saying there's not enough resources for families. So I operate primarily in Westmoreland County. Like I said, I'm from Westmoreland County Drug and Alcohol Case Management. So I've provided you guys with a little overview on Westmoreland County, especially if you're not from our county or if you're operating in one of the surrounding counties. We're close to Pittsburgh, but we are a little bit more rural. Median income is right around 40 grand a year for a typical family in our county, and the median age is about 45. So we're kind of right in the middle. We're not really urban. We're not really rural. There are pockets of like affluence in Westmoreland County, places where the neighborhoods are extremely nice, places where they're maybe not as well served. So we did recognize that there was a need to kind of bridge some of those gaps in Westmoreland. And looking at, looks like I have to click every time to advance these slides. So I have some data for you from the Westmoreland County Drug Overdose Task Force. I think they have some staff in the training today, dating back from the last few years. And we saw some pretty dramatic numbers when it comes to overdose death rates. Westmoreland County has one of the highest rates per capita in the state. I know that Cambria County, I think, is kind of up there as well. So in 2015, we saw 126 confirmed overdose deaths, 174 in 2016, and 94 were confirmed to involve heroin. That trend continued to climb in 2017. And I think the real shocker there is that we saw 141 confirmed to be involving fentanyl, which has been a major trend moving into the United States. I think it comes mostly into Pennsylvania, kind of from Ohio. So that was a new trend that we started seeing a lot more of in 2017. 2018, we saw 122 confirmed deaths. So there was a drop there, and I will tell you guys why in a second. And in 2019, we saw 90 confirmed deaths. And when I compiled this data in February, 14 of those were still pending investigations. So you can see that we are losing quite a few Westmoreland County residents to, the opioid epidemic. And these numbers don't necessarily even include just those individuals who experience drug and alcohol related crisis. And these numbers don't always speak to the number of family members who are impacted by overdoses, by the opioid epidemic, and by substance use disorders in general. What my team sees is a lot of older individuals who are impacted by alcoholism. For example, we see a good number of older gentlemen who are retired, who kind of, if you look at it from like a sociological perspective, you have that role change. And that kind of leads to an identity crisis. And a lot of people turn to alcohol after retirement as a way to kind of fill that gap and to fill that time. And boredom is a big trigger for them. So, these numbers are staggering, but they're also kind of just the tip of the iceberg in terms of how individuals in Westmoreland are impacted by substance use disorders. So to kind of reframe that, you can see on this bar graph you can see visually how those numbers climb. 2017 was pretty drastic. 2018 and 2019, we saw a drop. And I think that that's due to the efforts primarily of agencies like the Drug Overdose Task Force and like the Westmoreland Drug and Alcohol Commission, who have introduced Narcan initiatives into Westmoreland County. But the CET team came about because Westmoreland Drug and Alcohol really recognized the need, because drug overdoses are not just like a mental health substance use disorder treatment issue, they're also a medical issue. And what Westmoreland, the Drug and Alcohol Commission, really acknowledged the need to pair with our first responders and our EMS professionals, who are kind of the first ones through the door when these situations are occurring. So CET is kind of on the front lines as well of helping to respond to some of those issues, but we didn't come about until March of 2019. So we are kind of on sort of like the downward trend of those anti-overdose efforts. Am I going too quickly? Are you guys all following still? We're good? Nobody's popping up in the chat box, so I just want to make sure I'm checking in. And something else that we work to address is that disproportionately these drug overdose deaths are occurring in people who are my age. We're looking at the 21 to 30 and the 31 to 40 range. What my team sees is the vast majority are probably between 26 and like 33, 34 is probably the range of age that we see the most often. And something that I don't think gets discussed quite enough is a lot of those people who are my age who are losing their lives to the opioid epidemic are parents. So we're seeing a lot of grandparents who are raising children because their parents are incarcerated, they're in treatment, or they lose their battle with the substance use disorder. So that's part of what the Drug and Alcohol Commission also acknowledged a need for in establishing the CET team. So we are able to support and engage those individuals' families as well. So there's a lot of words on this slide, and I'm not necessarily going to read it, but Westmoreland Drug and Alcohol Case Management's community engagement team is kind of a mouthful. Again, we are like Westmoreland's mobile drug and alcohol crisis team. We work in conjunction with the University of Pittsburgh's Program and Evaluation Research Unit. We call it PIT-Peru for short. Some of their staff are also participating in the webinar. They implement what's called the Strategies for Coordinating Overdose Prevention Efforts, or the SCOPE program. And the SCOPE program actually encompasses several counties. That's a program that Pitt is employing that provides an electronic app for first responders to be using, EMS's paramedics to be using on the ambulance trucks, where they are utilizing the NIDA single question screen and the DAS-10 to screen all responsive non-overdose patients for drug and alcohol concerns. They have gathered emergency room data that suggests a certain range of people could benefit from screening for drug and alcohol that just don't get it because the ERs are typically kind of underserved, and they don't always have the drug and alcohol specialization or capability to engage those individuals the way that we are trained to do. So the EMSs are kind of our first point of contact, and they're our primary referral source. So the community engagement team accepts referrals from two sources. One is EMS and first responders. We are contracted with 3 different EMS agencies in Westmoreland County. We have Rostraver, we have North Huntingdon EMS, and we have Mutual Aid Ambulance Service, which is probably our biggest provider. They utilize the iPads and the apps built by Pitt Peru through the SCOPE program. They screen their clients, and if the client consents and they meet the criteria for a referral for the CET team, the EMS then call me directly, which is an amazing thing. We now have a direct service linkage to our first responders. There's a paper process and a referral form that they fill out for documentation purposes. But once I get that call, my team and I are able to dispatch. Sometimes we're able to meet the client right at the hospital if they accept transport from EMS, or we are able to engage in home if they refuse transport. Sometimes they go to the hospital and they are discharged before we are able to engage. But if the client meets criteria and the client consents, we are able to immediately put boots on the ground and go screen and assess the client and bridge the individual to treatment. This is especially useful in overdose cases because we see a lot of re-overdose. I don't know if that's a clinical term, but individuals who are receiving Narcan in an overdose situation sometimes do not accept transport, they don't accept treatment, and unfortunately they return to their using environment, they use again, and now not only do they have still the substance that caused them to overdose initially still in their system, now they're piling extra substance on top of that. And that makes it all that much more risky and does increase the likelihood of death. Our other referral source is Westmoreland Drug and Alcohol Case Management. They're able to, if a client is involved in coordination of services, if they're involved with our certified recovery specialist program, and the client just is not engaging. The client maybe has had an assessment, has maybe been involved with case management for a little while, but suddenly we're not able to reach them by phone. Suddenly they're not coming into the office anymore. They're not responding to their CRS, but they are a high-risk, high-need person. The community engagement team is able to go knock on doors. So we have that unique ability. And as of right now, the community engagement team is the only team in Pennsylvania doing this exact thing. There are several places that have similar models, but no place that's doing this exact thing. I believe Blair County is in the process of establishing their own team, and I think the SCOPE program is expanding to them as well now. But it's a pretty incredible situation where we're able to unify our EMS and first response providers, our case management units, recovery support. We're able to communicate with outpatients. When we refer our clients to an outpatient provider, we follow up with them. So once we have screened and assessed an individual and we have bridged that person to treatment, we don't just drop them. Because we recognize that so many people get lost in between the levels of care. I'm kind of a systems theorist myself. I believe that individuals function best when they are kind of plugged in to all the different services within the treatment system. And that includes, the different levels of care as well as case management. So for example, if we screen, assess, and bridge an individual overdoses, we screen, assess, and bridge that individual to detox. That individual steps down to a residential program. Oh my goodness. That individual steps down to a residential program. We will coordinate with their residential counselor to help create an aftercare plan for that person. Whether that means outpatient, if it's medication assisted treatment, if it's 12-step, if it's smart recovery. I myself am an individual in long-term recovery, as is Austin Hickson, the CRS who works on this team. We are also in the process of hiring a third team member, and the person that we are looking at is also an individual in long-term recovery. So the team is conducted entirely of recovering individuals, which is also an advantage because at times we can go in and speak to the individual because we have walked those steps as well. We have been to some of those places. The three of us have completely divergent pathways of recovery, so we're kind of able to cover all of those bases. And that really helps the individual to relate, to have somebody to, we use some warm handoff procedures. I think most of you are probably familiar with what that means by now. It's a term that kind of hit the scene a few years ago where we talk about, we walk with a client the whole way to the recommended level of care. CET and Westmoreland Drug and Alcohol Case Management, we kind of jokingly call it warm hand holding. That was a term coined, I think, by Kelly Nabuda. She's in the house as well. But we call it warm hand holding, where we stay with the client and we monitor their progress. We help to meet their needs every step of the way. So if an individual is in residential treatment, looking for an outpatient program, looking for medication-assisted treatment, looking for 12-step meetings, we bridge them to certified recovery specialists or CRSs that can help walk with them as well. And then we bridge them down again. So, from IOP to outpatient, or even to like sober living environments, we've bridged individuals to halfway houses. So all pathways, all levels of care are open. We are able to connect individuals much more effectively than probably previously was able to be done, because we are able to kind of track them down in the community rather than waiting for them to come to us or to call us, or we're continually trying to call them. Because as many of you know, I'm sure, sometimes the phone even or transportation can be a major barrier to the client. We're kind of finding that out right now as we're moving more towards telehealth initiatives. I think we're realizing like, oh, we're actually able to connect maybe even more now than we were before. So some statistics from this slide. On CET, we started in March of last year. So this March, it has actually been a year that our program has been up and running. And the grants that we are based on are good through, I want to say 2021. Is that 19 plus 3? I don't math. I'm a social worker. I don't do math. Or 2022, I think, will be the end of our grant-based programs. The Westmoreland Drug and Alcohol Commission, when they recognized the need for these programs, they did the footwork, they put boots on the ground even before we did to obtain the funding for these programs. So we are 1 year into a 3-year program is what I'm getting at. So since March of 2019, and these numbers are about a month old, so we actually probably have numbers a little bit higher now, but these give you a good ballpark of what we have done in the last year. So since our inception, we have engaged 108 individuals who survived overdose or who experienced another type of substance use related crisis. And this only is reflective of the number of individuals referred to the team by local EMS. So that doesn't include the case management referrals for individuals that we have already seen. These are brand new referrals, brand new screenings, brand new assessments. So we engage those individuals. Of those, 71 accept screening and assessment and bridge to treatment. So that's a pretty high percentage. I don't know exactly what 71 of 108 is, but I would imagine it's probably right around 70%. So that's pretty unprecedented. Of the 71 individuals who accepted screening and assessment, 62 actually decided that they were going to go to some form of treatment. And I'm trying to make sure I just accidentally closed my chat window. We'll see how that goes. So 62 individuals, again, it says warm handoff, but we apply more of a warm hand holding process. We stay with the individual over the course of their engagement with recovery, because we believe in a long-term assertive community engagement model. So we're going to stay with that person. In addition to bridging to treatment, we also do bridge to, I just got an alert. I'm not sure what. Oh, look, chat. Thank you guys. I am still sharing my screen and I am still working on that slide. I talk more than I use my slides. So yeah, Julie, I'm still sharing and I can see you now. Thank you. So in addition to referring individuals to treatment, the community engagement team also recognizes that treatment is not the pathway for every single person that we engage with. And not every single person that we screen and assess is going to accept an actual referral to a level of care. So they might say, yeah, I'll talk to you, I'll sign the paperwork, I'll get started with you, but I don't want to go to rehab, I don't want to go to counseling. We're able to link them to recovery support services. So like myself, like my partner Austin, we have a team of certified recovery specialists at Westmoreland Drug and Alcohol Case Management who are available to be of service to our clients. So we can also make a CRS referral. And that's really important because, you know, of the 108, 71 accepted assessment. Of the 71, 62 went to treatment. So we've lost probably almost 50 clients who maybe didn't really engage with anything at all, but then 26 are still willing to engage with non-clinical recovery support services. So they are still getting some kind of engagement from the community engagement team, some kind of referral and follow-up. And the CRSs are really, it's really an incredible and irreplaceable, invaluable service in that they are also, like myself and the rest of my team, the me too of recovery, the I've been there, the I know how that feels. And sometimes that's the only voice that an individual in early recovery is willing to hear. So it's a really great way for a person to kind of get their foot in the door if they're not really sure about this whole recovery thing. You know, if they're nervous or they just want kind of more like a peer to talk to rather than like a clinical professional. We also have conducted a lot of family support engagement. So we go into, especially when we go into the home, we never go alone. We go as a team, not only for our safety, but also because sometimes it's useful to split an individual from the family if everybody's in the same household. So if there's more than one of us involved in an engagement session, you know, I might engage with the client, the CRS might engage with the family, or vice versa. And we do spend a lot of time encouraging the family members to acknowledge that addiction is a family disorder. We recognize that, and there's really no denying that. You know, I used to have a coworker who used to explain the impact of addiction as kind of like a grenade, that when it goes off, it's not just right here. You know, it blows into pieces, and the pieces fly into everyone around us. And we kind of explain that to the families, and we connect them with their own independent counseling services. We connect them to our recovery community organizations. We have a few of those in the county. Sage's Army is probably the biggest one that we are connecting individuals with right now. You know, but the RCOs are doing absolutely incredible work with families in the community. And that's another one of those missing blocks that we are able to kind of set in place collaboratively for the individuals in the communities that we serve. So CET is kind of like the glue that is like filling in some of these cracks in the system for a lot of these people. So we do recognize, you know, there is that need for ongoing family engagement as well as individual engagement. So some of the services that the CET team provides, I know I've already touched on some of these, but specifically more on what we do for the families. We do provide Narcan training and leave behind kits. Those are supplied to us by the Westmoreland Drug and Alcohol Commission. We are Narcan trainers. We can show families and individuals how to administer Narcan, how to identify an overdose situation. If you've been through the Narcan training, you kind of know that process and what that looks like. We are also able, again, to provide families with referrals to agencies that support the families, including for funding, especially the Westmoreland Drug and Alcohol Commission. We also encourage the families to reach out to Al-Anon and Nar-Anon, which, if you're not familiar with those programs, I'm sure you probably are, but for those who might not be, those are kind of like 12-step fellowships that are designed for the family of the individual with the substance use disorder. They are kind of 12-step based. They have their own system, their own program, and they also do really amazing work with the families. The RCOs, which I have mentioned, independent family counseling, which I have mentioned. We are able to kind of encourage individuals to look into programs that can provide access to funding for grandparents who are raising grandchildren. There are state-based programs that we help them to research and learn about. So some of that is that education piece for families as well, who may not know, you know, here we're in this situation and it feels really dire and we don't know how we can afford this or address this. And then again, long-term treatment options for the individual. So this includes alternative housing, halfway houses, three-quarter houses, you know, connections to, there's a pretty substantial 12-step community that also provides long-term recovery-based housing options for individuals that it doesn't involve treatment at all. We also offer phone and in-person support. So we are able to have recurring sessions in the home. We are able to return to visit the individual and the family. We call them to check up on them, even if the client has been doing well and we don't hear from them for a while. We still make a habit out of just kind of checking in on them, almost kind of like what the MCOs do when you have like a high utilization case manager. That person who just checks in, make sure the person is doing well. Hey, do you need any more connection to services? Are you struggling with any linkages? And that kind of thing. So we ensure that the client is not just supported in the initial early stages of recovery. We also make sure that they are supported ongoingly. We do still have several families that are still engaged with the CET team. I think that number is probably in the 20s. I think it might have been on my last slide, but we do still engage quite a lot with the family members, especially while the individuals are in treatment. The family has questions. They're not sure of procedure for like dropping items off. So we're kind of also like a treatment concierge for the families who have never experienced the treatment process before as well. So just some points that I like to acknowledge when I talk about the community engagement team. We do recognize that addiction is a family disease. So we don't just engage the individual. You know, my personal belief is I've been asked at times, what do you think is the cause of addiction? Where do you think it comes from? And I can tell you that having been through it myself, I don't think that there is necessarily any one specific cause of addiction. We know that there are genetic linkages. We know that there are environmental factors, you know, and there's always the discussion of, you know, what is the gateway drug? And I don't think that there is a gateway drug. I think the gateway to addiction is trauma. And I think that trauma is sometimes our missing piece. And that if we fail to address trauma within the systems in which an individual functions, that we are kind of missing the point. You know, and that impacts the family. When we look at like the nature versus nurture debate, you know, is it your genetics or is it how you were brought up? Well, that kind of negates the impact of the individual's environment. It doesn't take into account the peer group. It doesn't take into account what normal means growing up in a certain environment. And the community engagement team is able to really get into that environment where counselors might not be able to go. or other treatment providers might not be able to go, we can physically lay eyes on what an individual is experiencing in the home, what the family dynamic is like, and how trauma might manifest not just in the individual, but also within the family system. And we also recognize that just the addictive lifestyle itself is traumatic. Being an individual with a substance use disorder, having to do some of the things that these individuals feel they have to do to sustain that lifestyle, even just the shame and guilt and the internalized identity of being an addict or an alcoholic, those are heavy words, and what that means. So, that's something else that the team is very aware of when we're approaching an individual, is that even if there is no major identified traumatic event that led to the development of an addiction, we understand that being an individual with a substance use disorder in and of itself is trauma. We specifically pay attention to grandparents who are raising their grandchildren. Again, with that resource support, that connection to the RCOs. There's a lot of places where support groups are offered where they can talk to each other and have that kind of sense of community, so that they don't feel quite so alone, because you're not standing in the middle of the supermarket saying, oh, my son is a heroin addict and I'm raising his child. Those aren't things that people generally say in public, again, because of stigma. We also like to educate our families on enabling and secondary trauma. So trauma doesn't just impact the individual when something nasty happens to them. Trauma can also be kind of vicarious. Trauma can be, if something really bad happened to somebody very close to me, I can still feel that. Or if I witness a trauma, or if I'm caught up in, someone else's reaction to their trauma, we encourage the families and the close, like live-in relatives or spouses or roommates, to acknowledge that this individual's addictive lifestyle really does impact me as well. Hi, Colleen, I see you're raising your hand. If I open the Q&A box, is it going to?
Go ahead and try it, see if it works.
Okay. Oh, yes. So Colleen asked me to note how we are working with clients during the pandemic, which is an excellent point. So we are still engaging. So we actually just took an EMS referral earlier this week. And what we are doing is engaging assertively by phone. So we're really not placing ourselves in a position, because team safety is my number one priority, after the client, but I'm not going to place my team into a situation where it would just be overtly unsafe. So when we are receiving referrals from the EMS, we are trying to engage with the client immediately, especially if that means that they are in a hospital setting. The individual that we engaged earlier this week, we were able to link her with a telehealth assessment. So if you guys aren't familiar with telehealth, we were able to do kind of the same as what a face-to-face assessment looks like. I think the state and the federal government have both lifted provisions on 42 CFR Part 2 that allow us to obtain verbal consent. So we are still able to help those individuals. I think I just froze. Did everybody hear that? Maybe. Okay. So we are still engaging individuals by phone. We're still engaging the families by phone. We spoke to the individuals. Thank you, Bob. We spoke to the individual's mother. We were still able to provide family support. We are not stopping operations. We are a crisis-based team. So we continue to function as best we can within the health department's regulations and suggestions. We are splitting time between working in the office and working from home, but we're still present just as much as case management is. And the interesting thing I think about this whole pandemic situation is that it has actually, I think, increased the cohesion in the case management unit. So we're able to kind of share some of those duties. So these people are getting actually more people involved in their assessment and care than they were before the pandemic. So we are still functioning. But that is the community engagement team in a nutshell. Colleen, do you think that there's anything else that I might need to cover? Do we think we're good? Okay. Oh, I see your hand is raised now. Okay. So I do know I will bear with Colleen here. And that might have been from when you raised your hand before. But we are going to open up for a Q&A. I have the chat box window and the Q&A open, and it looks like everything is still functioning. So, ooh, that's no fun. Thank you, Julie. I think you did that. Again, just a reminder that there is a survey at the end of all of this that you guys will be able to complete, and you will get a certificate for that. So with that, I will open up to questions, comments.
If someone wanted to get Narcan, if someone was on this call and they wanted to get Narcan, especially now because like people can't access it a lot, who would they call?
So they could call us at Westmoreland Drug and Alcohol Case Management. They can reach us 24/7 at 1-800-220-1810. That would probably be the most efficient way. So I have a couple of questions here. We have some in the chat box and we have some, wow, you guys have a lot of questions. This is awesome. Okay. So I think the first one that came through was from Bob. Are your funding channels still open for these community needs? So this program, CET, is grant-based. So yes, we are continuing to function. The Westmoreland Drug and Alcohol Commission, our SCA, is still functioning. So yes, the funding channels are still open and available to bridge individuals to treatment right now. I'm assuming you're meaning within the pandemic. So yeah, we are still operational from the funding end. Do we get to share some of our success stories? We do sometimes. The tough part about the success stories is that obviously, I'm sure as many of you know, that our work is largely confidential. So a lot of that information has to be sanitized. But I can tell you, yes, Carm, I have a spiral staircase. I'm sorry, that distracted me. I can tell you that we are still following several individuals. One individual that I can share on in particular, who is an older individual, kind of, I don't want to say frequent flyer because that sounds kind of, I guess, unprofessional or blasé, but this person is an individual who has repeatedly sought treatment, been through case management, been to several residential facilities, has had a CRS long-term, has tried one of the 12-step fellowships and just didn't really function very well. But that individual did just recently complete a stay in treatment. And that individual is currently maintaining recovery right now and continually says how grateful that person is to be in recovery in the pandemic, given the limited availability of that person's substance of choice. So we do have a lot of individuals who are still maintaining recovery, fortunately, through the pandemic. So yeah, sometimes we get to share, but not all the time. So I see, can you tell me more? I will answer live. about the supports you offer to grandparents and how those individuals are referred. So typically the individuals that we interact with are the result of the individual who was referred by EMS. So when we go into the home, we don't always know who they're living with or what the situation actually is. So sometimes it's by surprise that we are engaging with grandparents. But usually our first step is to refer them to individual counseling or to an RCO or to both. And the recovery community organizations host family groups for those individuals, for families who have lost a loved one, for parents who are struggling and grandparents who are struggling. There's so many good questions coming up, and I hope I get to all of them. But typically we go on a case-by-case basis. There are certain incentive programs available through the state that can help incentivize grandparents. They offer stipends for raising children. There's legislation available for them. Yes, the Lancaster hotline is a good one. Thank you very much, Kelly. There's a link there in the Q&A. Kelly is the queen of resources, you guys. So if I can't answer it, typically Kelly is my go-to person. So if you see Kelly Nabuda popping up in our chat windows, she's providing lots of links for grandparents. But again, we do that normally on a case-by-case basis. And you can always call Westmoreland Drug and Alcohol Case Management, again, at 800-220-1810, and we can provide you with more information on that. An individual struggling with addiction absolutely can call case management and get help, Tina. Again, that's that number that I just gave, 800-220-1810 is the number where you can reach us. And again, you can always reach out to the Drug and Alcohol Commission if you need that information. They are also an excellent resource. So Molly, this is a really great question. During the pandemic, how do AA and NA meetings work? Are they offering video conferencing? So yes, they absolutely are. So I'm a member of a fellowship myself, and I can tell you that I have been doing meetings through Zoom online, the Zoom platform, which is exactly pretty much like GoToMeeting. It's pretty much the same thing we're doing right now, only there's like 30 people on the screen, and it gets a little bit overwhelming, but overall it's been really, really good. So AA and NA, we also have a phone hotline. We have websites. So individuals in the fellowship are also still able to access meetings, yes. There's also really great apps and resources for recovering individuals. In the Rooms is probably one of my favorites. You can download that to your cell phone, and I actually keep it on mine. In the Rooms provides links to all of the fellowships. So it's not just AANA, it's also for eating disorders, for sex and love. They have all kinds of different fellowship information available. And through that app, they can also link to online meetings. So In the Rooms is a really, really great resource. So hopefully that answers your question. I will pop back over to Bob. I'm just trying to make sure I'm not missing anybody at all because there's a lot of really great questions. Bob, you asked, how does your work look during the pandemic? Can you do recovery and treatment without doing it face-to-face? So the support groups for youths. Okay, we'll get to that. Recovery and treatment can be done without face-to-face. Obviously, nothing can really replace that face-to-face interaction. Most of our residential facilities are still open admission. They are still accepting clients. However, we are having difficulty placing clients who are positive for COVID-19. But for healthy individuals, we are still able to place them in residential, and we are able to do telehealth. So I know a lot of our outpatient providers, I know specifically SPHS Behavioral Health is doing telehealth sessions. Our CRSs are doing telehealth where they can do video, they're doing video. So our work has changed a little bit, but not as much as maybe the specific clinical treatment providers are. case management has been employing telehealth for a while already. So I think we were kind of fortunate in our ability to make that transition pretty quickly and pretty efficiently. So it hasn't changed much. Support groups for youth under 18 who are using in New Ken and Lower Burl. So that's a tough one, and Kelly Nabuda might have some resources on that, but I can tell you that the 12-step fellowship is not age discriminatory. So we do have youths who come to, excuse me, I'm like obsessed with hot tea right now, you guys. It's saving my life because I don't want to cough even a little bit at all, because I feel like that's like the forbidden thing right now. So the 12-step fellowships are not age discriminatory. They're LGBTQIA plus friendly. So especially for, if you have a youth who is looking at 12-step support, that's a really great option. You can search for your district of AA or your area of NA. I know that for NA, it's Central Westmoreland Area of Narcotics Anonymous, or CWANA for short. They have a website, and I want to say that our district of AA is 42, but I could be wrong. Let me search that really quick for you so I give you an accurate answer. It looks like we are PA District 42, I think. I want to make sure. And the website is under construction. Of course it is. But you can search for those meetings online. As far as specific to the New Ken and Lower Burl areas, unfortunately, Lori, we understand that New Ken and Lower Burl are kind of underserved regions, and Kelly may be able to chime in and provide more information on that. But my best suggestion would probably be 12-step, just because they are not age discriminatory. The link, so Tony is asking, the link that was provided, you can't see it. It needs to be emailed with the certificate. So I don't know if, Julie, you can see the link and the resources that Kelly Nabuda has shared in the question and answer box for the Lancaster Grandparents Hotline, for Kid Connector Hotline. If you are able to throw those into an email when you send them to people.
Yeah, if Kelly could just put all that into a document, then we can send that out with our certificates. That'd be awesome.
Fantastic. And I can't see if Kelly's still in or not. So if she is not, I will hit her up when I get back to the office, or I can send her an email. But we will make sure that that information gets out. If at any point too, you guys want to contact me by email, I'm going to give it to you. So if you need a second to grab a paper and pen, my email is lihoffman@SPHS.org. So it's lihoffman@SPHS.org. Make sure you get the LI part, because there was another L Hoffman, and that gets confusing. So lihoffman@SPHS.org. Thank you guys. There's very kind words coming up as well. So thank you so much. Can you mention, oh yes, the LDA. So Lost Dreams Awakening is definitely a great resource in New Ken. They're another one of our RCOs. And they are also fantastic. So they are kind of akin to Sage's Army. They do a lot of community support. I was trying in my brain, I think, to figure out where they were located. I couldn't remember if they were in New Ken or not. So yes, the Lost Dreams Awakening is also a really, really great resource. And you guys can Google them. They pop right up. I think they have a Facebook page. I know Sage's Army has a Facebook page as well. So those are great. Social media is a great resource, even just to find linkages to services too. Any other questions? Oh, I see somebody raised a hand. Colleen did.
We also have connections to recovery community organizations and different agencies on our website as well, www.wedacinc.org, if anyone wants to check that out.
wedacinc.org. Thank you. Oh, something else I want to touch on real quick that I actually kind of forgot. Westmoreland is a big county and we have a lot of hospitals. My team goes into all of them. So we have clearances for all of the hospitals in Westmoreland County, wherever our client decides to go with EMS. Oh, somebody else asked if our only referral source was EMS. As of right now, yes. So EMS are our primary referral source, aside from case management. So most of our referrals do need to come from EMS. That might change when the grant is over, but as of right now, our primary referral source is EMS. But if we get a client from EMS who comes to a hospital in Westmoreland County who is from an outside county, we're not turning that person away. We're gonna make the link to their county's SCA. We're gonna make the link to treatment or certified recovery support in their county. And if a Westmoreland County person gets transported likewise to a hospital out of county, we will also go within certain reason. So we've gone to McGee, we've gone to Shadyside, we've gone to Mercy. So we do, I'm so sorry, my dog is losing her mind. So we don't turn people down, and we will go out of our way to assist a client if we need to. Oh my gosh, I'm so sorry. She sounds way worse than she is. June. Hey. Oh my goodness. Okay. Colleen, I see that your hand is up.
I think she said she didn't raise her hand, so maybe that was an accident.
Oh. Okay. Okay. Did I miss any questions? She's a maniac, my dog.
Awesome. Well, if that's all the questions, thank you so much, Lisa, for all your good information. I'm sure everyone has learned a lot. And don't forget, whenever your your webinar closes, there'll be a link to a survey. And then also you'll be emailed out another chance to complete the survey and a certificate. And then when if Kelly can share the links, then we can get those out in the email as well.
Awesome. Thank you everybody so much for participating. This is a really cool experience.
Yeah, thank you. All right, thank you, Lisa.
Thank you. Are we all good to leave?
Yep.
Okay.
We are good to go.
Excellent. Thank you so much.
Thanks. Bye.
Bye.